Hi everyone, my name is Mary Grimberg. I'm the owner of ResilientRx Physical Therapy. We offer postpartum physical therapy. And today we're going to talk about some common diagnoses that can occur postpartum and even during pregnancy. And we're going to go over some common questions that you might have as a doula as well, and we'll also guide you on what it looks like to have a pelvic floor assessment. And so this will be more of some Q&A and then some general information, and I know you guys might be watching this on your own time, so feel free. Our contact information is on the last slide, so feel free to shoot us an email or message us and we can chat with you further. So all right, so like I said, I just introduced myself. I'm Mary Grimberg. I'm the owner of ResilientRx, and Michelle Andoy.
Hello.
Go ahead and introduce yourself.
I'm Michelle Andoy, and I'm a pelvic floor physical therapist at ResilientRx.
Cool. Yeah. So Michelle and I both treat pregnant and postpartum women as well. So, and then all right, we're going to scroll down here. Okay. All right. So there are really 4 common diagnoses that we see a lot of. And so we'll just kind of touch on those and give you a very general idea of what that looks like. And then we'll dive into how we would treat that after we talk through the pelvic floor assessment. So there are really 2 types of urinary incontinence. There's stress incontinence and urge incontinence. And so urge is more of, oh, I gotta go. They put, they feel like they're gonna pee their pants if they don't run to the restroom fast enough. Well, on the other hand, we have stress incontinence, and stress is more when you cough or you sneeze or you jump. That's when we have some leakage. There's also actually mixed incontinence where women can have both stress and urge incontinence as well. And so there's a lot we can do in pelvic floor physical therapy for this, and we'll talk about that in just a bit, where we're just going to briefly go over these. All right. And then another type of dysfunction, pelvic floor dysfunction, is going to be painless sex. So there's really 2 main types of painless sex, which just to generalize it all, is going to be pain with initial penetration, so vaginismus, and then pain with deep penetration, so dyspareunia. And so basically, the pelvic floor is 3 different layers. And so the first 2 layers really surround the opening of the vagina. So sometimes when those are tight, it can limit initial penetration. And sometimes you might find that sometimes women will say, initially it hurts, but then once I'm relaxed, it's okay. So that would be more pain with initial penetration. And then we have deep penetration. So they might be okay with initial, but as they hit certain areas of the pelvic floor, they might start to experience some pain. And they might not feel it all the time. So if you think of the pelvic floor, where the 3rd layer of the pelvic floor, the pelvis, the pelvic organs sit on top of the pelvic floor, okay? And there's a bunch of muscles on the bottom. It's like a bowl. And I'll show you in the next couple slides. You'll see what I'm talking about. But sometimes if maybe a muscle on the side here is hit, but the penis hits that side, it would be painful. But if we hit other areas, it may not be painful. So they may not complain of consistent pain with sex, but really any pain with sex is not normal unless they want it to be. So it's really just understanding that it doesn't have to be painful and knowing that there are treatments for it. And then Michelle, did you want to add on anything with that?
I also wanted to add with initial penetration, not necessarily just with sex. It could also be pain with inserting tampons or stuff like that. And usually that vaginismus or initial penetration is an involuntary tightening of the muscles. So a lot of times we see that it's very hard for them to relax those muscles on their own.
Okay. Yeah, that's a good point. Good point. Yeah, that's often what I hear as well. Just, sometimes they can't even tolerate a tampon. And do you hear that a lot, Amanda?
I haven't heard that. I've heard, the fear of the first time after giving birth and that having an effect. And also with GYN exams.
Yeah, for sure.
That's a big one
as a birth doula, that was always a red flag for me that, they had issues with GYN exams with their annual exam. I'm like, ooh, okay.
Right.
Yeah. Yeah. All right. Why is this not working? Okay. All right. The next common diagnoses we'll see is prolapse. And so there's different types of prolapse. So over here, can you see my mouse moving?
Yes.
Okay, so this is normal pelvic floor anatomy. So this is the bladder, uterus, vagina, and then we have the rectum here. So all of these are in their happy place. But what can happen is after giving birth or just sustained weight along the pelvis throughout pregnancy, we can start having symptoms of prolapse. So basically, it's just the pelvic organs falling down. And so we can have different types, but I'm just going to go over the two most common ones that you might hear about. That's going to be bladder, so cystocele, so bladder prolapse. Common symptoms of bladder prolapse are going to be, they feel like they have to double void. That's like the biggest key, is the double voiding. So what I mean by that is they pee and then they stand up and then a minute or two later they feel like they have to pee again. Yeah. And usually sometimes this can actually lead to chronic UTIs and infections, because what happens is, you see the image here, but what can happen is, say this is the vagina, the bladder's over here, the bladder can kind of fall into the vagina, so then we have some leftover urine there, and then when we go to stand back up, the bladder kind of fills back up. Yeah.
So they're not emptying their bladder completely. Correct. When they first sit down. Yeah. Okay.
Correct. Okay. And in general, this is kind of fascinating, but the bladder is never fully empty. There's always a little bit of urine in it, but so that's a common complaint that we'll hear of. And then the other common complaint is that they say they feel like they have a tampon in, and they don't. Do you hear that too?
Yes.
Yeah. Yeah. Michelle, do you hear that a lot?
Yeah, definitely. That's a big one.
And
they say to me vaginal pressure.
Yes.
Yes.
Yeah. Or they feel like their insides are falling out, or they just feel a little bit of a bulging.
Yeah.
Michelle, what are some other adjectives that you hear?
Sometimes I feel something coming out, and it's usually happening when they're standing because gravity is helping pull that down. I also do hear sometimes, not necessarily pain with sex, but they might feel more pressure. I don't really hear a lot pain with prolapse, but kind of like it gets in the way, stuff like that.
Yeah. I don't hear too much pain with sex or pain with prolapse, but it can happen for sure, especially if the prolapse has happened for a while. And then rectocele is basically just the rectum starting to prolapse here. Very common complaints are going to be everything we just described, except with the exception of they might feel like they wipe after having a bowel movement, and then they feel like they wiped enough, and then they stand back up, walk around, and then when they use the restroom again, there's some leftover bowel movement in their underwear, and they're like, what the heck? I just, I wiped really well. I don't understand. And they can kind of feel frustrated. And
so this is an actual, like the rectal wall is coming out. This is very different than a hemorrhoid.
Yes.
Yeah.
Okay.
Yeah. Michelle, did you want to add on to that?
Oh, I was going to say that the hemorrhoid is more with the blood vessels itself, and that if the woman is straining a lot, typically that leads to hemorrhoids. And I think that there are different types of hemorrhoids that I'm not too familiar with, and certain, you have to pay attention to color and all that stuff. But it's different from the rectocele.
Okay.
But I was also going to add that sometimes, it's going back to the cystocele, that sometimes people have incontinence with it and some people don't, which is a big one too. So that's also an interesting thing to.
Do you want to expand on that a little bit?
About why some people are leaking and some people don't with cystocele?
Well, how with cystocele they present differently than regular incontinence.
Right. So with the cystocele, I believe that as it's coming out, and there are different degrees of it, that's how we measure the prolapse, different degrees. So usually if it's going to like a second degree or third degree, that's when we start to see that there could be some leakage happening with that. A lot of times some people, they have a little bit of a prolapse and they're not really having any incontinence, which is okay, but they feel like they can't live or function with the constant feeling of the pressure, or that feeling of, I think there's a tampon inside me.
Gotcha. Yeah.
Okay.
The other thing you all might want to note to your clients are, well, first, yes, there are these options. There's pelvic floor physical therapy, because a lot of women think, oh my gosh, I have to have surgery. And
yeah,
regardless of if they do have to have surgery, they should do physical therapy before, because the surgery may not hold if they don't learn how to engage those muscles and how to control their intra-abdominal pressure. So if they're not controlling their breath and then they're bearing down right after that surgery, it may not be as successful. So either way, they should go to pelvic floor physical therapy, because it's learning how to engage those muscles. It's learning how to control your breath. It's learning how to strengthen your core. The other thing is too, sometimes women only experience prolapse with certain symptoms. So for instance, with certain activities. For instance, I had a woman who was probably about 4 or 5 months postpartum and just really wanting to get into weight training. And so weight training is a big debate. People wonder if they should even weight train when they have prolapse. And so a lot of it's really just understanding, like I said, how to control your breath. So if we hold our breath and go, huh, think of the pelvic floor and the diaphragm as a soda can. So the top part and the bottom part, if we hold our breath, it's going to push.
Yeah.
It's going to push that pelvic floor down. So if we can learn how to control our breath and then how to counteract that force of the pelvic floor contraction and be stronger all around, that can help. But if that's not enough, when we start getting to grade 3s and grade 4s, sometimes we need a pessary. So pessaries are basically orthotics for the vagina, and those can be helpful with certain activities. So maybe she doesn't need it. She didn't need it throughout the rest of the day. She was fine. It was only when she exercised and she did some weightlifting. So what we got her fitted for a pessary, and then with controlling her intra-abdominal breathing, she was able to return, and we did some physical therapy and stuff, easing her back into the activities. But it is possible to get back to that. And the way that I would describe one type of pessary can look like, if anybody's familiar with like a NuvaRing, just like a thicker NuvaRing, you can put it there. There's different types, and they would just have to be fitted for. Usually your urogynecologist will fit them.
Okay.
So yeah, physical therapists don't at this time in the US. They might outside the US, but yes. All right. And so the ones that we can really see more of in physical therapy or the ones that we see most commonly are rectocele and cystocele, and they both can happen at the same time too.
Yeah. Yeah.
I see that often. All right, Diastasis Recti, another common one you all might see. So this is not uncommon during pregnancy, right? The baby is pushing through the abdominal walls. The way that we know if it's more of a dysfunction is usually it's going to be, the way that we test it is we have them lay on their back and just flex their head up. And then we put our fingers in like the middle of their linea alba, which is the middle of the 6-pack muscles. So right here. And then we have them flex up and see if we sink in or if there's any coning, so pushing up through the abdomen. And then we go along the linea alba, so between the six-pack muscles, above and below the belly button, so the umbilicus. And then that's how we can kind of see. So you can see these are all different types, right? So it's around the umbilicus, below, above, full length. So not everyone's gonna look the same. And so common complaints are gonna be, I feel like I can't engage my core. I feel like my belly's bulging. I feel like I still look like I'm pregnant.
I have a pooch.
Yes,
that's a big one.
I actually have a couple of questions about this.
Yeah.
Sure.
So this comes up in my childbirth ed classes when we're talking about postpartum recovery and, you know, the when to return to exercise.
Mm-hmm.
So number one, my first question is it normal to have some diastasis in pregnancy?
Yes.
Mm-hmm.
Okay.
Yes.
That's what I thought, because a protruding uterus, right?
Yes.
Right.
Yes.
And it will tend to get bigger as she, you know, goes into delivery because the baby's growing.
Yeah. Yeah. And I read an article, and please tell me this is correct, because I'm telling my students. So, you know, usually the recommendation at 6 appointment is okay to return to exercise. And there's a whole range of the kind of advice that they get.
Can you start? I cut out for a second. Can you repeat?
That's okay. Usually what I hear from my students or from anybody is at the 6 to 8 week appointment, you know, you get the green light to return to exercise. And some care providers are very explicit or specific about how to do that. And then just some say, go for it, right?
Mm-hmm.
And what I'm telling my students is to start very slowly with no to low impact, and then gradually increase, and then being very strict about abdominal exercises and waiting for 12 weeks before they're doing curls, abdominal crunches, stuff like that. Because I read an article about giving yourself a full 12 weeks for, if you have diastasis, for that to possibly heal. Is that?
Yeah, I mean, there's just so much information out there that it's hard to say one size fits all, which we were talking about before. For most people, it might be fine. But it's overall, I don't know how much in the article talked about, it's not as much closing the gap as it is improving the tension. Have you heard that before?
Yeah, that it didn't talk about it at all. It just talked about not doing abdominal crunches at 6 weeks.
Okay. Yeah, I mean, that might not
engaging your core definitely at 6 weeks, doing those types of things, but not those types of things.
For sure. Yeah. And again, it really depends on the person. What if usually shorter women with shorter torsos will have more diastases because they have nowhere else to go.
Yeah.
Maybe a taller woman with a larger torso may not have as much, so they may be able to, but the only way you would really know is if you saw a pelvic floor physical therapist to know, you know, what's okay and what's not. But generally speaking, yeah, allowing your body to heal before you increase all the pressure by doing a crunch, you know, I think that's that can be a safe thing to say.
Okay.
Right. And also I was going to add that, you know, it varies in terms of like the amount of weeks that you should wait. What's also pretty common is we have those very enthusiastic fitness people after giving birth, and they really want to go back into their pre-pregnancy routine. And then sometimes when they hear that they have to wait 12 weeks, it becomes really almost like depressing for them because they feel like they can't live their lives. So we don't like to work so much with like never do this or never do that. So we always have to work with what's going to, you know, how they're going to function during their day. And then of course get their doctor's referral on that. And most of the time they clear them for PT, and then we teach them how to activate the core correctly, and then how to do those activities without making the diastasis worse.
Okay.
Yeah. And so I'll just kind of touch on this. So the old school thought is to close the gap. And this is actually changing because we're starting to see more, it's about increasing the tension. And what I mean by that is if we do that the crunch and I'm here, okay? And then we can kind of see, you know, we can assess how many widths we have of our, you know, our fingers, right? And when they do that, it's about how do I sink in and keep going, or do I hit kind of like a hard stop? So they might be separated maybe by 3 or whatever it is, but if I don't sink in, they might have a diastasis, but it's they're functionally fine.
Okay.
Hypothetically speaking, right? So that's how we would notice it. So they may still have the separation, but they're not having the coning. They can increase the tension in the abdominals, so they're safe to, you know, it may indicate that they may not have a diastasis. And this is very general information, but we're trying to shift the focus from closing the gap to increase the tension, increase your function, decrease fear. Because there's a lot of fear surrounding by a diastasis. There's a lot of clickbait on social media. There's a lot of clickbait on YouTube. And it's really frustrating for providers because we have to undo all the psychosocial fear that is occurred. So they think, I can never do a crunch again. How are you supposed to get out of bed in the morning? This isn't like functional movement. And so if we're going to scare people into moving, that's a whole kind of other thing versus like, we might have some limitations for a few weeks, you know, like you were saying. But it's not never do crunches again. And, you know, this is a soapbox I could go on because I see it.
It's good for me to hear. It's good for me to hear.
Because I hear it in all types of physical therapy. Like people are told never to do squats again or all these things. It's just those, I mean, you have to squat. I mean, how do you use the bathroom? You don't just
how are you going to live your life?
Exactly.
Yeah. So really, I think the most important thing, and a lot of women come in, and once I kind of help calm their anxiety down about it and just tell them, hey, it's okay. Like, you know, we just are easing into this, and, you know, just educating them just on that can make a big difference. Because like I said, there's a lot of fear surrounding this, and usually it's kind of on YouTube or social media because they want the clicks on the video, right? So kind of keeping that in mind so your clients know that. But yeah, I could go on and on about that. Michelle, do you have anything you want to add?
Oh no, I think I'm pretty good with that. I mean, they've been doing there are a lot of new studies now, like especially like long-term studies on diastasis, and now it used, like what you said, it used to be close the gap, and now it's tension the connective tissue, or tension the linea alba, and they did a lot of really good studies on that. So
yeah, and though, just to kind of give you an idea of what this would look like in treatment is, so that we have 4 abdominal layers. The deepest abdominal layer is going to be the transverse abdominis. It kind of wraps around, so the fibers kind of wrap around like this. So it's like our natural back brace or core brace. And so when we learn to engage that, it can help increase the tension of the linea alba, so that way we get more core control and then can do the activities that we want to do. So for example, what I would do is just the client today, laying on the back, having their hands just above their hip bones. So we'll have them just kind of here and slightly inward. And they wanted to sink their belly button towards their spine without sucking in, rotating the pelvis, or holding their breath. So it tends to require a lot of cues. But what's really cool, and I do this with my clients a lot, is I'll say, hey, okay, they'll be concerned I have diastasis, and so I do the test and I can see, I'll say it's above the belly button, right? And I'll have them feel it themselves. I'll flex up and be like, yeah, it's there. And then I'll say, and I'll teach them the transverse abdominis and say, let's do it again. And they're like, oh my gosh, it feels so different, you know? And it's almost just reassuring to them that it's gonna be okay.
Their body works.
Yeah. I nerd out on that, but and So then it would just be gradually loading those tissues. And what that means is, okay, well, we did it laying on your back. Well, maybe let's try a plank on the wall. And then I feel their diastases while they're doing it, or can they maintain the tension? Yeah, you're maintaining the tension. And I have them feel on whether or not they can feel if they're engaging or not. Because the biggest thing is so they can know if they're having any symptoms of diastases. And so that's the big thing. And then gradually getting them to a full plank position. So maybe then planking on a table, planking on their knees, and then planking on the ground. Like anything else, just gradually loading that. And then those are typically the most aggressive ones. And then, you know, with that, then having them do crunches if they can engage their transverse. And then it's typically okay. Like you can tell if you're coning, then you're not doing it right. So don't do a sit-up. I think that's a really good kind of general overall thing is if you sit up and you're coning, you may not be ready for sit-ups yet.
Right.
But if you control it, cool. I mean, very general, but Michelle, do you want to add on anything there?
I think you talked about it. You went over it really well. So good job with that.
What about, I'm sorry.
Go ahead.
The use of binders. So that's a new thing, not a new thing, but a lot of mamas are wanting, I get that question in my childbirth classes and also postpartum clients. They've bought this binder that of course never fits, but you know, I've heard that I should start using this binder to prevent or treat diastasis. So
that's a good question.
Just that general using a binder, an abdominal binder after you give birth.
Right.
Yes, no, in what situations is it recommended? What does it treat or correct?
I have some opinions on that. I mean, it depends.
I'd like to hear.
Right. I think it depends on what kind of binder they're using. A lot of times those abdominal binders can be very limiting and they're not very comfortable. And then also it hinders the actual muscle facilitation. So like actually getting the contraction. So if they're wearing a binder all day, they're not strengthening at all. And they're just having this support around their abdominals. So it might not actually do something unless they feel that their diastasis is giving them back pain, or if they're feeling that along with that, then that might be a good idea to use a binder, but it shouldn't be something that they stick with throughout the entire postpartum period, because at some point they should learn how to correctly engage the core. Yeah. They have some abdominal binders that they can use during exercise that actually help, I guess what you could say is bring the muscles together and help facilitate muscle contraction. Those type of binders I think are better than the other binders that just strap you along your entire like torso. Yeah. And brace you in.
Yeah.
Right. Yeah.
Yeah. Okay. It's not a one size fits all. So I'll do like today I considered potentially talking to a client about one because it worked a few weeks on getting this transverse activation, and she just is having a lot of trouble getting it. And that's not uncommon, but she couldn't engage. So when I did press and approximate her lower rectus abdominis, she could engage better. Right. And so what I actually did is I had her hold like a belt and kind of wrap it around her, so it was kind of pulling this way. Mm-hmm. Does that make sense?
Yeah.
And then I had her do a few contractions, and then once she really learned how to do it, we kind of just took the belt off, and then she was able to engage. Versus if then even with that, and then I took it off, then I'd be like, okay, we might talk about a binder, but it's not, you're pregnant, you need a binder.
Right.
So.
Okay. Thank you.
Did that answer your question?
It does.
Okay. Good.
Yeah. So then what does a pelvic floor assessment look like? So generally speaking, we look at everything that could be the reasons why we have a pelvic floor dysfunction. So first, we're going to look at back mobility, maybe even mid-back mobility, ankle mobility. We can assess functional ankle mobility and hip and low back mobility. And so that we would generally kind of look at these things. We can look at them through like a squat or range of motion exercises, things like that, we're trying to figure out why did this pelvic floor dysfunction happen. Most of the time it was because of pregnancy, but we still may have underlying factors that can cause pelvic floor dysfunction. So again, looking at hip strength, low back mobility, hip mobility, because all these things can come into play in limiting normal function of the pelvic floor. So what I mean by that is, so if I'm arched like this, it's going to be harder for me to engage the pelvic floor muscles on the back. If I'm tucked, it's going to be easier for me to engage the back muscles, but not as much in the front. So we might work on neutral spine there, because we have really a front and a back part of the pelvic floor muscles. It's really hard to just isolate them and only do one group unless you're really in a different too arched or too tucked. So, you know, that's why we look at, you know, the hips, the back, and all that stuff, because somewhere is going to take up the slack. And so ankle mobility too. So sometimes if they're doing a squat, Michelle just did an eval a few weeks ago where they were doing a squat and, you know, noticed that their ankle mobility wasn't as good. So then they're kind of shifting higher up to compensate. And so maybe there were some issues causing then hip tightness, which then part of the hip muscles attached to the inside of the pelvic floor. So then you can get that, right? So it's important that you're looking at everything, not just the pelvic floor.
Yeah.
So, you know, we get their history, and then we look at all the things that we just talked about, and then we talk to them and see if they're comfortable with an internal assessment. And so we talk them through that, and we talk through, you know, how we talk about there's the 3 pelvic floor muscles. The first 2 layers are going to be, we line them up based on the joints in our fingers. So this is going to be first layer, second layer, and then third layer. And so we assess, you know, the tissue tightness, how the scars are moving, if they have any scars, how they're contracting, how long they can contract for, how strong the contraction is, are they even contracting? And then second layer, same thing, and then third layer, same thing. Biggest thing that we do in the third layer is what you can see in this picture here is the third layer is like a bowl. And so are
you getting the model?
Yeah.
Extra fancy.
Yeah. Okay. So this is going to be the first layer. And then the second layer blends in with the in between the first and third layer. So you really can't see it too much, but you can see how here, the vaginal opening, we've got these muscles kind of surrounding here. So you can see if they're tight, initial penetration is not going to be fun.
Yeah.
And then internally, the picture that we see here, our pelvic organs sit on top of here. So the ones that we saw on the previous slide here. So they all sit on top of here. Okay. So we would go internally just like this picture, and we'd feel on those different muscles. So here, coincidentally, is our hip external rotator. So it turns our hip outward. So when we sit, so this is
cross-legged
rotation.
Yeah.
And that's what that muscle does. So if we have a hip dysfunction or a squat dysfunction or something like that, right, we can start getting some pelvic floor issues because it surrounds the walls of the pelvic floor there. And again, kind of the same thing where, okay, well, maybe they only have pain with sex sometimes. Well, we need to ask more in-depth questions. Well, what positions are painful?
Yeah.
Because if they're in a basic missionary position, they may not have as many symptoms versus if, you know, they're laying in a different position that might be hitting different sides of the pelvic floor wall, that might be painful, right? If somebody kept touching a sore muscle on your body, or, you know, when you've gotten a massage, you can feel, oh, that's a sore spot, and it feels like they're pushing harder and they're not.
Yeah.
So the pelvic floor muscles are no different. So if a penis is going in there, or if they're having the penetration in that spot, yeah, it's not going to feel great. And so that's also something that we work on, is internally kind of working on loosening up those muscles as well. So, and then, So that would be kind of the assessment. And then we do treatment. So the treatment would be, okay, well, if we found tight muscles, loosen them up. We would teach them how to relax their pelvic floor muscles through lower belly breathing, because when our diaphragm, this is our diaphragm and our pelvic floor, when we inhale, it pushes down and lengthens those pelvic floor muscles so they can relax a bit. So talking through that. And like I said, just depending on their diagnosis. So we've talked about, so we'll talk through, so treatment for urinary incontinence. Usually what can happen is urge happens when the pelvic floor muscles are really tight. And what that does is it triggers the bladder to thinking that it needs to pee. So when we get that, then we need to teach them how to relax those pelvic floor muscles, so then we can decrease the urge to pee. The bladder, you get an urge to pee when it's only 50% full. So it's pretty empowering when people know that, because they're like, oh, I know I don't have to go right this second. Just because I have to pee doesn't mean I have to.
Interesting.
Yeah, but really when it becomes an issue is if they're peeing. So normal is peeing every 2 to 3 hours. If they're peeing, I have a lady right now that's every 15 to 30 minutes, and now she's up to an hour and a half.
Wow.
So huge improvements. And that was just a lot of deep belly breathing, self-relaxation, understanding how to relax their pelvic floor muscles, internal relaxation of the muscles through what we're doing in here, and just really learning how to engage the core so then the pelvic floor muscles take up less slack. Or because and so if
I can imagine someone with urge incontinence not knowing what's causing that, and when she has that, she tenses up trying to control it, which is exacerbating.
Exactly.
Wow.
Exactly. And anxiety. So
yes,
we go into fight or flight mode. The first thing we do is like clench our butt, clench our butt, or clench our teeth.
Yeah.
So that's a big one. And then, Michelle, did you have anything you wanted to add?
Oh, I was going to add that sometimes depending on what their job is also affects it too. So like I've worked with people who have urge incontinence and they're nurses. So they're always on their feet and they have to hold in all the time. And that's not necessarily a good thing, because then you're kind of also retraining the bladder to only empty at certain times. And it doesn't really function well with their lifestyle.
Yeah.
So there's a lot of behavioral components to incontinence as well that we should look at, and also help the patient just like learn certain techniques of when, how to go to the bathroom at proper intervals, maybe holding it in, because sometimes they're getting that, I guess, phantom urge, or if they get the urge, but they don't necessarily need to go. So practicing those techniques to help them go to the bathroom at normal intervals.
Interesting.
Yeah, and also if they're peeing like every 15 minutes, think about the bladders. Inside of it has the detrusor, so it's the muscle that contracts the bladder.
Right.
So if I'm peeing, so this is the bladder, if I'm peeing every 15 minutes, I'm not expanding my bladder. So then what do you think is going to happen at night? They're going to have to pee because their bladder doesn't know how to expand. And so we see a lot of night frequency because of that. So it's getting that full expansion and then full relaxation. We need full range of motion in the bladder. But if we keep it here, we're training the bladder to stay here.
Yeah. Wow.
So the other thing that's kind of interesting too is a C-section scar. You need to once it's healed, moving the C-section scar is very helpful, because what it can do is it can bind to the bladder.
That was a big part of my PT. I had a C-section with my first, and we did a lot of adhesion management. It was pulling my bladder towards the left.
Yeah, it's crazy, right? And
it's crazy.
Yeah, and it's pulling it, and then it's limiting your ability to expand.
Yeah.
And if women knew this right after that, wound closed or the incision closed, they may not have as many issues with the scar and things like that. So I just wish that, I could go on and on about that, but.
Yeah, don't just schedule that. Don't just schedule that C-section to.
Yeah, I would have them double check with with their provider, but I would think doulas could tell them to move their scar potentially. I don't know.
Well, we can say, have you heard about adhesion management or scar management? Would you like some information on that? And we can send them to the resources. We want to cultivate a resourceful student or client, and hopefully prompt some questions. But we have to understand that we can't diagnose, right? Just have you heard?
Yeah, have you heard of moving your scar? You may want to look that up.
Yeah.
I've heard that can be helpful.
Yeah.
I think
and then send them to the valid information.
Yeah. And then stress incontinence is a lot of times can be just due to weak pelvic floor muscles. So maybe they're not even engaging their pelvic floor muscles. Maybe they had a tear. Maybe the scar is limiting their ability to contract the muscle. All these different things can happen. And like I said before, you can have a little bit of both. So it gets tricky when you do both, right? Because you need to strengthen with the stress incontinence. With an urge, it might increase it.
Yeah.
So we treat urge first.
Yeah.
But usually they go hand in hand. And I see this a lot too with diastases as well. They all kind of happen together. These all don't really I never see just one usually.
Yeah, they're all interconnected.
Yeah. So that's just kind of a basic understanding of that.
As far as, I was just explaining how we, bring up the subject and, encourage them to either talk to a care provider or research on their own or just start a conversation about it. But what is a good resource for a mom or even a student, not necessarily having pelvic floor issues, but curious about how to Kegel properly?
Mm-hmm.
Like, I would love for there to be a website that can teach women what is a Kegel and how to Kegel properly.
Yeah, maybe Michelle, do you want to? We should do a video.
Yeah, you can look at our Instagram page.
Yeah, we have a lot of really good information on our Instagram page, but we could definitely do some videos. And if you wanted to shoot us some videos you would like done, we can definitely do those.
Yeah.
They're common questions we get too.
Yeah. Okay, good.
Yeah. And then we talked a little about the Painless Sex, initial penetration. So intravaginally, we would go in and help stretch those muscles, or deeper, loosen up those muscles. What we can also do is we can provide them dilators, so like just different sizes that help stretch out those muscles, and they can belly breathe with that at home and help relax those muscles. They can even internally stretch. They can have their partner do it for them. It really depends on the person.
Yeah.
Other things can just be that sometimes women just need, I find that with women with young kiddos, it's hard to, for the lack of a better term, have foreplay. And so
seriously.
I don't think, Michelle, is there a medical term for foreplay?
I'm not sure.
It's locking yourself in your bathroom.
Pre-coitus. Because think about it, right? The vaginal wall dilates, we get lubrication, we get all these different things that are happening, and then we get clitoral stimulation, we get blood flow to the area. So if you're not getting all that and then you're just going straight
for it,
not gonna feel great.
Not gonna feel good.
So, sometimes I'll even suggest that, if you don't have time for foreplay because you're putting the kids down, talking about self-stimulation, things like that, because you need to get the lubrication. You need to get those muscles relaxing.
Get your body ready.
Yes, right. Exactly. Yeah. So it's a little bit of sex education. It's a little bit of teaching how to relax those muscles, maybe some dilators. There is a wand we can use. It's kind of like a little S shape that they can show them how to do that themselves too. So again, a variety of different things. And usually what I'll say is, if it's deep penetration in certain angles, I'll say still keep having sex, just maybe avoid these angles until you can tolerate it a little bit more, or maybe try to do some of the trigger point relaxation before and see how it feels. So Michelle, did you have anything you wanted to add?
Yeah, those are good points. I also just want to make a point that the postpartum hormones postpartum could kind of mimic like hormones during menopause.
Cause dryness.
Right. So that decrease estrogen. So it's very important, like Mary said, don't just jump right into it. You know, you're going to have to, you need that lubrication. So you might have to think about doing some type of either getting like a personal lubricant, or
that's what I recommend in my classes. Just start with that.
Right. Start with that. If you don't have the time for foreplay.
Yeah. Foreplay is not really an option for a lot of like new parents. So.
Right. Yeah.
No, but knowing that it's and understanding this can be helpful as well.
Yeah.
Mm-hmm.
But yeah, like Michelle said, the estrogen changes, it thins the vaginal wall, especially with breastfeeding. The other thing that can happen with breastfeeding is their oxytocin. So when men have sex, they release testosterone, or when they have an orgasm, and then female, we release oxytocin.
Mm-hmm.
So it's just that bonding hormone. Women actually get this when they're breastfeed. Well, you know this, with their breastfeeding. And so their sex drive might change because they're getting fulfilled in the breast feeding. Meanwhile, the partner, you know, might be confused. They both might be confused on what's going on by the sex drive. So knowing that too, that hey, it's hormones, right?
It is hormonal, yeah.
Yeah.
Plus, you're a little bit touched out by
you're like
that baby all day long.
All day already. Yeah. Cool. All right, prolapse. Really learning how to engage those deeper pelvic floor muscles, controlling your breath, because you know we talk about the diaphragm bearing down. If we're holding our breath, that can put more stress on the pelvic floor. And there's also something called vaginal weights that we can do as well. Those are helpful as well with urinary incontinence. So those are all just kind of general guidelines on, you know, what to look for. You know, those 4 diagnoses, we went over common complaints that the women will have, and then, you know, if they are interested in physical therapy, that, you know, they can reach out. We do offer complimentary discovery sessions, so they're 20 to 30 minute consults, basically, that the client can come in, meet us if they're nervous and not really sure what to do. You know, we can do that. We also offer complimentary 15-minute consults. So if they don't want to come in, but they just want to chat with us, we're happy to do that as well. And so, because it's scary, you know, a lot of people aren't excited to do this. So, but I know you had some questions for us. So
I've been asking them throughout. I've been interrupting you.
No, you're not interrupting at all.
They're good questions.
Yeah, it was.
You
asked about the prescription.
Yeah. You know, so I didn't know that there was a change in the law. I thought there was no direct access to PTs. You had to get the referral or prescription from your care provider. And you said that has changed.
Yes, that has changed. So the people that are watching, your clients can come directly to physical therapy. Well, depending on the provider, they can come directly to us, or it's basically they changed the law where you needed a referral to come into physical therapy before even doing any type of treatment. But they changed it where we have 10 to 15 business days depending on the provider. So they can come in and then we worry about the referral from there. So you all wouldn't have to worry about that. They can contact us directly.
And then I know this is a very difficult to answer this question, but on average, for the issues that you guys treat, a treatment plan takes 6 sessions, 12 sessions, or it's just too hard to say what an average would be, just to give a mom an idea of the commitment.
Okay. Again, very general, but if the sooner we see them, the less visits they usually need.
Yeah.
Like I have somebody that's 12 years postpartum. Yeah. We have quite a few visits. But if we're just talking straight forward postpartum, I mean, Michelle, you can chime in. I'd say, unless they had pre-existing stuff, I'd say 4 to 8 visits max.
Yeah, I agree.
I think a lot of them can get done, depending how quick they learn their body and we get them soon, maybe.
And how motivated they are too.
How motivated, and they do the exercises themselves. And how soon can you see them? 2 weeks, 6 weeks postpartum?
Usually we wait for their 6-week checkup, but and if they want to come earlier, we just want to have them double check with their OB just based on how their birth was and all those different things. 6 weeks is actually our cutoff. We would, with an internal assessment, we would do it at 6 weeks. Or later, but they can come prior. Michelle, what would you recommend?
I was going to say that if it's just like one diagnosis, like just stress incontinence, usually, are you talking, or when they can come in? I mean, it depends. If they get the referral from their doctor, then I would say, okay, that's the green light to go. But if they're unsure, then I would just go with like around the 6-week period.
Okay. That makes sense.
Right.
Yeah. Cause Amanda, what you were asking before is, when do we know when this stuff is normal?
Not normal, right?
So they might have symptoms of prolapse right after giving birth. They just pushed a baby out. Typically it depends on the OB. Usually 6 weeks is where some people can start to have intercourse. We did talk to an OB a few weeks ago who said around 4 weeks. So it just depends on the provider that's saying it, but generally we'll say 6 weeks. But that's because most tissues take 6 to 8 weeks to heal, and you'll know if it's not because you'll have dysfunctions, right? And so you might have urinary incontinence, their bladder might feel full, everything might be out of whack for a few weeks, and then if it's 6 weeks, things are still happening, then I'd say, hey, maybe we need to get checked out by a pelvic floor.
Mm-hmm. And I also like this recommendation to do the physical therapy before surgery.
Oh yeah, for sure.
Because so many people go straight to the surgery as the fix-all.
Oh, for prolapse, yeah.
Well, yeah, really for
any.
I think for anything.
Yeah, no, that's true. I don't know.
Almost anything.
All things, because you're gonna have to learn it regardless.
Yeah.
Anything. So, great.
Awesome, guys.
Oh.
It's so glad, nice to meet you and be able to get to know you, because it's I don't like, we don't like referring to people that we don't know, right? Well, I've heard they're good. Or sometimes we rely on clients. Clients will see someone and they've had really good success, and we're like, okay, I'm going to put their, put their number in my phone. But it's nice to get the chance to chat with you guys. There aren't many pelvic floor physical therapists in Austin, are there?
There's only a few.
Yeah.
But yeah. Do you, before we can chat a little bit further, but if you guys have any questions, feel free to shoot us an email.
I will, yeah.
Text this number. So if you're not sure, use us as a resource and we can help guide you.
Awesome. And I'll reach out to you guys about, those possible informational videos, especially like with Kegeling and,